Doctors Longo and Roberts discussed the current status of gene therapies in rare neuromuscular disorders in this 8-part podcast series. This is derived from the symposium that was presented at WORLDSymposium 2025 in San Diego, California on February 4 through 7, 2025, and is intended for healthcare professionals only. This podcast includes information about investigational compounds that do not yet have a regulatory approval or authorization for a specific indication. The safety and efficacy of the agents under investigation have not been established, and contents of this podcast shall not be used in any manner to directly or indirectly promote or sell the product for unapproved uses. The views, thoughts, and opinions expressed in this presentation belong solely to the author and are subject to change without notice. The contents of this presentation do not constitute an endorsement of any product or indication by Astellas. In this part, Dr. Longo will discuss the current treatment landscape and limitations in lysosomal disorders.
What I want to do today is just place gene replacement therapy within the current landscape of lysosomal storage disorder treatment therapy. Gene therapy obviously has the potential of treating lysosomal disorder to correct the root cause of lysosomal storage disorder. The gene is defective, and what happens is that you can potentially either fix the gene or bypass the lack of the genetic product. But there are already therapies that are existing and are functioning. So obviously, in many cases, the lysosomal disorder is caused by defective production of an enzyme, which is defective, and we can either replace the enzyme with enzyme replacement therapy or provide chaperone for specific mutations that retain the synthesis of the enzyme that, however, is not very functional. Another avenue that it is being reported is the utilization of substrate reduction therapy. As substrate accumulate, you prevent the synthesis of the substrate to reduce the accumulation of toxic material. What we know now is that this is not enough to produce many lysosomal disorders. In many cases, the lysosomal disorder results sometimes in impairment of intracellular trafficking and sometimes in the function of other organelles, and at the end it results in the activation of the macrophagic system and inflammation, and already we have some therapy acting at this level. So the end result of lysosomal storage disorder that there will be cell suffering and cell death, leading to a progression of the disease and morbidity and mortality. Now, what therapy do we have available already? So obviously, hematopoietic stem cell transplantation has been around for quite some time. It has been the same thing that we do with gene therapy, except that instead of reintroducing the gene of the subject, we place gene of a subject who is not affected of the disease. And this therapy has been proven effective in cases of MPS I and alpha monocytosis, but in many cases this has to be given way before symptoms start to be effective. Enzyme replacement therapy has been around for quite some time, starting with Gaucher disease, and now that it is available for a list of diseases that are there, so like Fabry, Gaucher, Pompe, different type of mucopolysaccharidosis, alpha monocytosis, acid lipase deficiency, 1 neuronal ceroid lipofuncinosis, and Niemann-Pick type A and B. Obviously, the advantage of this therapy, they give back the enzyme that it is defective, but the disadvantage that many times they cannot enter specialized area such as the brain. And there is already the second generation of enzyme replacement therapy that it is available, and with this second generation, some of the newer drugs are more effective in terms of cellular uptake or in terms of having a prolonged half-life and prolonged activity. Then there are pharmacological chaperone therapy, And the one which is FDA approved is migalastat for Fabry disease. Under study is ambroxol for Gaucher disease. The disadvantage of this therapy that only a selected number of mutations respond to this therapy. Substrate reduction therapy has been introduced for Gaucher disease many years ago with miglustat, and it was followed by eliglustat. And both of them are effective, and some of them more effective than others, simply because of the fewer side effects of eliglustat as compared to miglustat. But at the same time, eliglustat does not pass the blood-brain barrier. Finally, the newer agents that are orally administered, N-acetylleucine and arimoclomol, both approved for Niemann-Pick type C, they act more on the downstream effect of the lysosomal storage disorder, either by stabilizing neuronal cell activity or by reducing the inflammation that is present in the brain. Now, what are the limitations of the current therapy for lysosomal storage disorder? Obviously, one of the great limitations of bone marrow transplant is that you need to have a suitable donor, somebody whose HLA match with you and can donate the blood. That still remains a big problem, especially in certain ethnic groups. And the way around it would be to do exactly what Dr. Roberts has shown, to do ex vivo gene therapy, where you take the CD34 cell from the subject, you introduce the defective gene, or you fix the defective gene, and then you put it back, doing an autologous bone marrow transplant that obviously would be accepted much better by the body. In terms of enzyme replacement therapy, the problem is that many times it is inefficient in cross-correcting different cells. In other words, some cell will pick it up, but sometimes it doesn't reach certain tissue, and those tissue will be refractory to the action of enzyme replacement therapy. The other thing is that they require lifelong infusion, in some cases once a week, in some cases every 2 weeks. That obviously it is a big burden on patients and their family. All enzyme replacement therapy pose a risk of immune reaction every time that you do that. And obviously this needs to be mitigated either by the use of pre-medication or sometimes with the need of having available drug to rescue anaphylaxis. And last, many of them, all of them that we have currently available are unable to cross the blood-brain barrier. So the way around it is the localized administration, with the administration, for example, within the brain or within the central nervous system with different ways. Pharmacological chaperones are wonderful drugs. However, again, the number of mutations that they can correct is very limited, and that greatly limits efficacy of this type of approach. Finally, substrate reduction therapy is effective, but the problem is that many of the compounds whose synthesis is inhibited are really essential for the functioning of cellular membrane and other cellular functions. So in other words, the therapeutic interval is very limited. We have to give a certain amount, but not too much, because otherwise we might impair some basic cellular functions that are essential for life. So obviously it is possible to bypass part of this problem by delivering them only to the tissue that need them by using lipid nanoparticles.
In the next part, Dr. Longo will discuss gene replacement therapy in lysosomal disorders.